Hi, everyone. My name is Dr. Allissa Desloge. I'm an associate professor at University of North Carolina at Charlotte. I'm also one of the faculty leaders for the Charlotte MCH Maternal Child Health Workgroup here on campus. We are so delighted to welcome you to our Crucial Conversations series. Our May presentation is going to be focusing on rural maternal and child health, and this is going to look at both within the states, but also globally. So it's going to be a really nice opportunity for us to be talking things maternal and child health at a more global level. So we are so excited that you have decided to spend some time with us on this Friday. And without further ado, I'm going to introduce our two presenters for the day. And then, as we mentioned, please drop any questions that you have in the chat. And we will make sure that we get those answered as we go along and wrap up today. I'll also be sharing some announcements at the end of the presentation. And so if you're able to stick around and check out some of the other things that we have going on through the work group, that would be really great. All right, so I'm going to start by presenting our first presenter is Liane Ventura, who is a current PhD student in public health here at UNC Charlotte. Prior to coming to UNC Charlotte for her PhD program, she was a really wonderful researcher doing work in Western North Carolina and through East Tennessee State University. She was faculty there as well, and so is bringing a bunch of rich data to us and background in understanding rural health within the state. We also have Dr. Allissa Desloge, who is an assistant professor here at UNC Charlotte in public health as well, but epidemiology and community health for those of you who are familiar with our transition this year. And she is going to be talking about some of the work that she's done in Illinois and also globally. So we're super excited to hear about some of the research she's been doing in Malawi. Without further ado, I'm going to turn things over to our first presenter, Liane. Liane, whenever you're ready, you can take over screen sharing.
Okay, hello. Thank you so much, Dr. Dahl, for the wonderful introduction. And I think I'll need to minimize this. So please give me a verbal to just confirm you can see my screen.
We can. Looks great.
Okay, excellent. Thank you. So thank you so much for the invitation to present today about maternal health in rural North Carolina. I'm very excited to dive into this topic with you, and I'll go over what is rural and data sources that I've been working with, and will really end by kind of pulling it all together with some recommendations. So I wanted to get started as we think about rural and the geography that consists of our rural landscape, to really take a moment to express deep appreciation for the stewards and caretakers of the land, and pay respect and honor to Indigenous caretakers from time immemorial until now and into the future. And so before we kind of dive into me doing a lot of talking, I wanted to open up to the group to say, like, what comes to mind when you think about rural health? And I wonder if you can post those responses in the chat, and then I can read those out as they come in. So lack of access to care, traveling long distances to get care, transportation barriers, homeopathic treatments, limited resources, farmers, limited providers to choose from, misconceptions and holistic approaches, poor health outcomes, mental health stigma, mental health, smoking, stigma. All right, well, thanks for your participation on that. Definitely a lot of really common thoughts that surround rural health, and we will go over, I think, a lot of those in this presentation. So to set the stage, now that we're kind of in the mode thinking about rural health, I'll really dive into rural health in North Carolina. So North Carolina is a very large state that's over 500 miles wide, and it consists of 100 counties, and 55% of the state is rural. So actually more than half of the state is classified as rural, and that is according to the 2023 Rural Urban Continuum Codes that are designated by the USDA. And North Carolina is comprised of 3 regions. So as most of you, I'm sure know, there's the mountains to the west, which are the Southern Appalachian Mountain Range. The middle of the state is the Piedmont. And so it's that area that's the foothills of the mountains before we get into the eastern region, which is the coastal plain, and of course is that Atlantic coast. So a lot of really rich geography throughout North Carolina, but also really different and unique historical contexts and cultural roots throughout the entire state. So as I mentioned, rural urban, as we typically define it, is measured in different ways. And so we might think about total population size, population density, proximity of an area to a more metropolitan area. We might think about administrative boundaries like counties, zip codes, or census tract. And a lot of these measures are binary. So as I just mentioned, rural versus urban. Also, some researchers use more categorical measures, such as rural, suburban, and urban. These measures of rurality could also be continuous from 0, which is very low rurality, to 100, which is very high level of rurality. What we use or have used is the Rural Urban Continuum Code, which comes from the USDA and takes into account county and zip code. And that is a function of population density and also proximity to metropolitan areas. The index of relative rurality is the continuous measure, which takes more of a multidimensional approach that includes population size, population density, percentage of urban within a county boundary, and is again a more continuous measure. So it may be more useful perhaps in certain contexts. And so these different measures of rurality in a research context can be used in different ways for different projects, different purposes, and depending on the audience. But wait, what really is rural? Fisher and colleagues in 2024 published an article that looked at these different measures of rurality as used by researchers, such as the RUCC code or the IRR continuous measure, and found that there is actually very little overlap in how these measures categorize rural. So this map here shows the dark green areas are the rural categories, and the purple are the more urban categories. So again, a lot of variation in what is considered rural. So what components are missing in these measures as commonly used by researchers? Well, heterogeneity of cultural context within rural. So as I mentioned, North Carolina, spanning from the mountains to the coast, has very unique cultural and historical attributes throughout the state. There are also within county variabilities. So some counties might be larger or smaller than others and comprise an urban core, but more rural outlying areas. So by categorizing one county as rural or urban can miss this within county variability that we might see in real life and have implications for things like federal funding, which is determined based on rural or urban designation. And then, of course, there's people who live in these counties or in these regions, and their perception of whether or not they consider themselves in a rural area. And that might even be different for different people in the same area. For example, if someone is working and needing to commute long distances to get to work, or having different levels of access challenges as compared to maybe even their neighbor. And then there are the economic factors that may potentially underlie what we think of when we think of rural. And these have been studied in the context even of cultural heterogeneity as well as geography. So some economic factors, as you have mentioned, are including lack of access to healthcare resources, less economic earning potential, and all of that is more or less characteristic of a rural area. However, there are opportunities with rural, and we might consider including strength-based approaches, such as considering the social capital that is really unique within rural areas, like the connectivity of individuals and social networks, norms of reciprocity and trustworthiness among community, and also resiliency. There are natural resources like percent of tree coverage, environmental amenities like rivers, lakes, beaches, trails, vistas, mountain vistas, beach vistas, open space, and also agriculture, forestry, hunting, fishing, and foraging. So some of these natural resources might be something that we want to consider when we really dive into rural health and the context in which we think about rural health. So with the data sources that I'll present today, they are from a project that is entitled Maternal and Child Health in Western North Carolina. documenting access, and consulting with community. So the project included development of a GIS dashboard, as well as primary data collection with surveys and focus groups. So I will present the secondary dashboard data and focus group data as well. So the team that worked together to conduct this research included my colleagues at East Tennessee State University, Dr. Kate Beatty and Dr. Chen Huang, as well as our collaborators at Western Carolina University, Smart Start of Transylvania County, as well as many community partners and research participants without whom the research really wouldn't be possible. And then also our funding agency, the Dogwood Health Trust. So the Maternal Child Health Dashboard, a little bit about that. It is a GIS tool that is aimed to support policy and programmatic efforts that are aimed at improving maternal health outcomes as well as social determinants of health. So the dashboard is really a curated source of public and semi-public secondary data, which comes from federal sources, philanthropic sources like the March of Dimes, and state level data such as from the NC Center for Health Statistics. And we co-developed the dashboard with community engagement studios and public health practice partners. So our practice partners were very helpful in identifying measures that were very important to include in the curated data set. The focus groups were conducted with community members and providers. So there were a total of 18 individuals from across both groups. And those folks who participated were from throughout Western North Carolina, and those were conducted just last year in 2024. They were virtual focus groups and audio recorded, transcribed, and coded. And the team that led this were the Western Carolina and Smart Start teams. So I'll present some of the risk factors and social determinants of health that we think about when we think about rural health. And I will note that our project had specific focus on transportation, broadband access, measures of healthcare access as it relates to maternal and child health outcomes in Western North Carolina, but also the state. So I will show quantitative results from across the state while highlighting the focus group voices that do come from that mountain region. So transportation and broadband, as it was noted by some of you earlier, lack of transportation is absolutely a consideration when thinking about rural health. And there are significant differences between rural counties and urban counties in North Carolina, particularly with the no broadband access as well as no vehicle access. So rural areas have over 18% lack of broadband access, and that is at the county level. So some counties, more than 18% of individuals have no access to broadband. And one provider who was part of the focus group highlighted that when you're in a rural community and there's a monopoly, then it's too expensive for many families to afford to have internet in their homes. Or if they have internet, many of them have to buy the special router because they're so remote that they can't pick up regular internet. So the focus groups really highlighted these different components of lack of access, which include monopoly of who's providing the internet, which drives up the cost, but also a really challenging access to where the speed or the quality of the internet isn't acceptable. And so moving to transportation, more than 6% of individuals at the county level in rural North Carolina do not have access to a household vehicle. And one community member emphasized that sometimes the distance for specific types of services, if you don't have your own car, it's just not there's no easy way to get there. So again, that lack of access that many of us do characteristically think of when we think of rural health. And it's interesting to note that we did not set out to examine food insecurity in particular, but those concerns did arise during the focus groups. And so again, rural areas are significantly more likely to be experiencing food insecurity at a rate of over 16% at the county level. And some quotes to really exemplify this challenge for our rural communities is that, as a community member said, our family receives food stamps and we have 5 family members to feed, and the money is dried up halfway through the month. A provider said, families do not seem to know how to access food programs to get food. There are many federal and local programs, but it is difficult for families to navigate. So as the focus group theme highlights, there are challenges not only with food access, but with navigating food access programming. Regarding healthcare access, there are significant differences in OBGYN rate at the county level between rural and urban counties in North Carolina, and also significant differences between rural urban counties with no health insurance. And rural, again, has more than 12% of people in the county who have no health insurance. And then the accessibility of OBGYNs is less than 6%. As a community member said in the focus groups, insurance will not pay the bill for urgent care because urgent care is not considered a primary. And I'm like, okay, can't go there. It's emergency room for everything that my kids need when their pediatrician is not open. So that really speaks volumes to not just the lack of health insurance, but also the low access to providers. So all of these different risk factors culminate into adverse birth outcomes. And one really important birth outcome that March of Dimes really highlights in their work and is something that we speak about a lot in our work, and I think really champions in a way this measure of birth outcome at the population level, which is preterm birth rate. So that is when an infant is born before the full gestation period. And there are many risk factors to considering preterm birth rate, including health insurance coverage, which we just discussed, socioeconomic status, also health behaviors like smoking during pregnancy and pregnancy planning, which might include short interval pregnancies. So in this map, the hash marks are urban counties or counties that are classified as urban, and the counties with no hashes are rural. And the darker yellow are the higher rates of preterm birth. So just visually in this map from the GIS dashboard, we can see that rural areas have those higher levels of preterm birth rates. So this is a very powerful tool to communicate health outcomes at a population level. So I'm really thankful to the team that worked together to generate these really rich sources of data to explore rural health in North Carolina. So I'll end with some recommendations based on this work, which includes the importance of focusing on bright spots. So I noted earlier the importance of thinking about rural health assets. And so thinking about counties that are doing really remarkable community health improvement work and what is going well and how can we replicate those efforts. Also infrastructure development at a policy level and the state level. So thinking about standing up broadband infrastructure across the state. Also leveraging the GIS technology to conduct multi-level analyses that take into different dimensions of rurality that I also discussed earlier. And those qualitative methods to help us understand the stories of folks with lived experience in rural areas, as well as how folks identify with that identity of being rural or how they experience rural health challenges. And again, community engaged research where we can strengthen and build academic community partnerships and tailor our work to those heterogeneous rural communities that we seek to serve. So I thank you very much for the invitation and for your time to hear me speak. Very grateful for you to be here. My email is posted to continue the conversation. And some references.
Thank you so much, Liane. If you have any references to drop in the chat for folks while Dr. Desloge gets set up to shift the conversation to some of her work, that would be really helpful. And then if anybody has questions for Liane, you could go ahead and drop those in the chat. We will also have open questions at the end where we can potentially answer from both sides. But if anybody, due to timing, needs to take off early, go ahead and put that in the chat for Liane and she can maybe respond to that for you. Otherwise, we'll take those questions after Dr. Desloge's presentation. Dr. Desloge.
All right, you seeing my screen okay?
We do now, thank you.
All right, awesome. Well, thanks so much, Liane, for kicking off this conversation. You all will see that there are a lot of parallels that exist in these rural settings, no matter whether it's North Carolina, Illinois, which I'm going to talk about first, and then Malawi, which I'm going to talk about second. So just for some context, again, my name is Dr. Allissa Desloge. I'm an assistant professor here at UNC Charlotte. However, did all of my doctoral research at the University of Illinois, Chicago, in partnership with some individuals who were also living in Springfield, Illinois, which is surrounded by more of the rural counties. So that's kind of how I got involved with this work and introduced to the project that I'm going to be talking about. So project background, just want to highlight this project was originally initiated by Dr. Christine Zimmerman, who's affiliated with the Department of Family and Community Medicine at the University of Illinois Chicago of Medicine, Rockford. And this project was funded by the National Center of Advancing Translational Sciences. Dr. Zimmerman was able to get a K award to kind of kick off this research, which was really exciting. And so she was really the brain behind this project. I was grateful enough to join her as a research assistant during my doctoral program to help with the analysis of the quantitative and qualitative data that I'm going to talk us through today. So essentially what this project started as was a quantitative survey of 54 rural dwelling pregnant and postpartum persons around healthy behaviors, really trying to assess more so physical activity and nutrition behaviors. And then of those who indicated that they were living in a more inactive lifestyle, we contacted to do 16 semi-structured qualitative interviews. So just some demographics about the individuals that were in the study. And again, these are all rural dwelling pregnant persons. So 69% had some college or less education. 33% had a household income of 28,000 or less. On the flip side, about 33% had an income of 85,000 or more. The rest were really kind of in the middle range. It was 87% individuals who identified as white, so it was not a very racially diverse sample. 48% were primiparous or had never had a previous birth. 34% were not employed, and we choose the language not employed instead of unemployed because a lot of these women were choosing not to work and stay at home and raise their kids. And then 31% were on Medicaid or moms for babies insurance. And then, as I mentioned, we looked at those 54 people who took that quantitative survey on health and behaviors. And of those 54, 29 or 56% indicated that they were physically active for 30 minutes on 2 days or less. And so since it was only 30 minutes on 2 days or less, we would put them in this category as like sufficiently, insufficiently active, and then contacted them to do a qualitative interview to just learn a little bit more about what some of the barriers and facilitators were to physical activity. And of those who ended up participating in these qualitative interviews, 80% had some college or less education, 93% were white, 33% were not employed, and 33% were primiparous. And I know that I was just telling you all that we set up the survey to really understand health behaviors. And if people have questions about the barriers and facilitators to physical activity and nutrition, I can talk about that as well. But for timing's sake, what I'm actually going to dive into, which what seems it was of interest to a lot of you based on what you put in the chat, is mental health. So again, even though this project as a whole was really focused on physical activity behaviors, of the 52 survey participants that provided data on their mental health, 20 or 38.5% reported having at least one mental health condition. So as we were analyzing the survey results, this was something that really piqued our interest. Having one or more mental health condition was significantly associated with education, those with a lower education having a higher likelihood of having a mental health condition, employment, those who were not employed having a higher likelihood of a mental health condition, and transportation insecurity. So those that were experiencing transportation insecurity having higher likelihood of a mental health condition. So that was all from a bivariate analysis. And then ran a logistic regression using backward selection, so kind of doing a multivariate analysis at this point. And when doing a multivariate analysis, found that those who were not employed were actually 3 times as likely to have a mental health condition. So their odds ratio or risk ratio is significantly increased. So from this slide, again, we were able to see, okay, quantitatively, a lot more people than we had initially anticipated have a mental health condition. We're seeing that there are some of these socioeconomic factors that are associated with having a mental health condition. And we were really curious to see if in our interviews, in which our semi-structured interview guide was solely focused on physical activity behaviors and things around healthy pregnancy, if anything would come up around mental health. And so again, to clarify, we asked no specific questions around mental health, but we had a lot of data and themes and quotes related to mental health. So we'll get into that now. So among interview participants, so those 16 people that we invited for an interview, 7 or 44% reported having one or more mental health conditions. So again, that was information we got from the survey. But then to dive into some themes and quotes, so we kind of broke up our major themes into drivers of mental wellness and drivers of distress at different levels. Those of you who are familiar with the ecological model, starting with the community level, some drivers of mental wellness for rural dwelling pregnant persons, including available community programs. So one person specifically referenced that her county health department actually offered a doula program and that was really beneficial for her, having kind of that go-to person to help navigate the pregnancy. Also, neighborhood and workplace initiatives. So a few people talked about, obviously, their neighborhoods or their workplaces having community centers or having programs that honestly really benefited overall wellness, including incentivizing physical activity and how that then impacted their mental well-being. A lot of people who were involved, who were working at the time, spoke a lot about how we'll see here in this drivers of distress that your workplace policies really were a big kind of driver of if you were mentally well or mentally distressed. So kind of going over to the drivers of distress, we see this one quote, when I went to that last doctor's appointment, my blood pressure was sky high. My nurse was like, what is going on? I said, my job is stressing me out. If there's one thing, there's 10 million more. And that specific interviewee talked about how her job really was not supportive of her pregnancy, her going to her prenatal appointments, giving accommodations in the workplace setting around her being able to sit down, putting her in more stressful situations. And then again, on the flip side, we saw that like a community level driver of distress was around neighborhood safety. So a few people really telling us stories around witnessing violence at the community level or experiencing intimate partner violence, and obviously that being a driver of distress. So moving along to kind of the interpersonal level, as far as relationships that individuals had with family and friends, again, these really mirror each other as far as being either a driver of mental wellness or a driver of distress. When thinking about drivers of mental wellness, having that familial and friendship support was really important. Individuals talked about how their partner or even their already existing children just brought joy into their life or really supportive in going through everyday tasks. Having a friendship, even if it was someone who was not in person. This quote says, I have a friend out in California. She's been a big motivator in life with everything. When I set a goal, I'll tell her my goal. When I finish, she'll say, good job. And I know that really might sound silly, but it makes me feel good. So friendships, even if they aren't in person, but having those people to really support you was beneficial to overall wellness. And then again, thinking of drivers of distress, having any sort of familial trauma as far as loss or violence, and then really being socially isolated contributed to distress. And again, thinking about these rural dwelling pregnant persons, a lot of them did speak about social isolation, specifically those who were not working and so weren't interacting with individuals perhaps in a work setting or a workspace and maybe only had their family that they were interacting with in a regular basis. So one person said, I think it would actually be good for me to get out and meet more people who are pregnant and having kids around the same time as me because I don't have any friends here. My friends are all back home, so it does get kind of lonely sometimes. I really won't have anybody. So again, thinking about going forward for recommendations and programs and such, really thinking about how we can get rural dwelling pregnant people connected. And then at the individual level, some drivers of mental wellness, including motivation for being well for their baby. Anyone who does maternal health work knows that a lot of women are so motivated to do things on behalf of the baby. They're going to prioritize the well baby visits ahead of their own postpartum visits. And so a lot of people really spoke of just being motivated for the sake of the pregnancy and for the sake of their baby being well. A lot of individuals, again, since this was a project focused on physical activity, talked about the benefits of physical activity for mental wellness. Two participants actually specifically mentioned yoga and how that was calming and really helped when they were anxious or stressed out. And then third, the joys of pregnancy. Some of these interviews were actually really beautiful in the framework and approach they took to speaking out pregnancy. This quote was one of my favorites of, a couple times I did get nauseous, but it actually made me happy because I knew that that meant the baby was growing, he was healthy, happy, and doing well. So again, that interviewee on their own kind of flipped the script when talking about symptoms, which can sometimes not always be the most exciting aspect of pregnancy, but talking about how that actually brought her joy. And then drivers of distress, including being worry for baby in pregnancy, as far as if there are any concerns. This particular participant said I had to go to the psych ward because I'd gone off my psychiatric medication because I was so worried about the baby. So thinking about those with pre-existing mental health conditions and how they navigate pregnancy, as far as if they are going to or not going to stay on any medication that they might be on. Even that process, this interviewee talked about giving her a bit of anxiety, having to talk with her doctor about making that decision. Body image is something that came up, as far as maybe having some body image or body dysmorphia issues throughout pregnancy and the postpartum. It was mentioned by a few participants. And then just balancing responsibilities within the home. So having potentially work responsibilities, having these at-home responsibilities of taking care of the kids, doing the laundry, doing housework. A lot of individuals referenced how this other responsibilities really took up a lot of their mental load. So not going to go into this now to save time because I do want to leave time for questions, but some additional findings that were interesting around COVID-19. We did find that a good portion of our rural dwelling population, 46%, were never vaccinated. A lot of that was around having concern for side effects of them and their baby. And we had a lot of quotes around how they didn't really feel like they were adequately counseled by their providers. So again, this was additional finding that we didn't really anticipate, but COVID-19 ended up coming up a lot. Happy to talk about that further. So given our time, I'm going to quickly try to go through this aspect in like 5 minutes, but I really am happy to answer any questions about the background of this project, if anyone is interested, but I'm going to kind of torpedo through to the findings. But when I was doing my dissertation research, it was actually in partnership with those at the Kamuzu University of Health Sciences, which is in Blantyre District, Malawi. So for those of you who don't know, Malawi is a country located in East Africa. Blantyre District is the southernmost region of Malawi. And again, this project was in partnership with the Kamuzu University of Health Sciences. So shout out to them. This is kind of a map showing the rural urban density of Malawi. I actually can't speak to Malawi in the same way that Liane could speak of North Carolina in terms of RCC codes. There is no official body that designates whether something is or is not a rural area. We can look at maps like this that show where areas are more or less populated. And then as far as with my work, we actually did end up giving designations of rural, peri-urban, and urban. And those were really just based on population numbers and advice that we got from experts on the ground. So there are no specific codes or designations for rural or urban in this setting. So essentially, this project was a randomized controlled trial focused on group prenatal care. Not going to go through this, but again, want to shout out the PI of the study, Dr. Crystal Patil, who was at the University of Illinois Chicago at the time, now is at the University of Michigan. And this randomized control trial was funded by the Institute for Nursing Research at the NIH. It was a trial that was focused on group antenatal care, which is when you attend antenatal care in a group of 8 to 12 women as opposed to individually. In those sessions, you start out with an individual health check which is like just a belly check to make sure everything's going well. And then for the next 45 minutes to an hour, you do interactive discussions and interactive learning on various topics in pregnancy. So for this study, we'll lean in on this clinical setting variable, which I'm not sure if you can see my screen, but on the bottom left corner here, we have this clinic setting variable. So in this study, which is across all of my entire district, 30.6% lived in a rural area. And I can say that those who lived in this rural area were more likely to have completed primary school or less, as opposed to secondary school. And a lot of individuals that were living in rural areas had high likelihood of food insecurity. As you can see, food insecurity was actually experienced by 68.6% of our population. So those living in rural areas experienced it as well. But that was a big indicator of those living in rural settings. But really kind of diving into the findings that were related to rural health. So I, again, specifically was looking at mental health for this study using the SRQ, which is a measure of psychological distress. And when we're looking at the SRQ, a higher score indicates more distress. So if we're looking at this column here, we can see that there was a higher mean SRQ score for those living in rural areas compared to peri-urban areas, and then compared to urban areas. This difference was statistically significant. And when I went on to do multivariate linear regression, did find that those who were living in rural areas had significantly higher levels of psychological distress. You can dichotomize the SRQ into distressed and not distressed. So make it kind of a dichotomous variable. And again, same trend here. When we're looking at rural areas, we see a higher percentage of those who were experiencing distress compared to urban, peri-urban, and urban. So storyline, which a lot of us know coming into this, those living in rural areas had higher levels of distress. But one thing that was interesting is that we did see throughout this trial that those in group antenatal care saw a more significant decrease in psychological distress compared to those in individual care across everyone in the trial. And so there was no significant difference in the change in psychological distress based on clinic setting. So this was an exciting finding for me to really indicate that the intervention worked across these different settings. It's not like it didn't have a significant change in the rural areas. So this is really exciting to be able to see that in our rural clinics, it also had an impact. And I'll spend this last minute just kind of going through some additional thoughts. These aren't research-based. These are anecdotal as far as mine and the research team's experience in conducting this trial. So recruiting clinics in the rural areas was the most challenging. I flew past this part, but there were 7 clinics, 3 of which had that kind of rural designation. And we faced a lot of barriers around participating in these rural areas. A lot of it had to do with stigma and mistrust with the health system. And it took a lot of community work and partnership with village leaders, with religious leaders, for them to understand kind of what this trial was about, what we were trying to do, that it wasn't going to have anything to do with biometrics as far as like taking their blood or anything. So again, there was a lot of misunderstanding and distrust of the health system generally in these areas. They did come around, and now these settings like love this model of care the most, but it was definitely an issue in the beginning. Implementation had some challenges just around like having enough women to participate in the group in the time, having enough midwives being able to lead. The way that midwifery is kind of done in Malawi, midwives are assigned to these different government clinics. And a lot of midwives want to leave working in the rural clinics and go to the more urban clinics. So there's a lot of staff turnover, which isn't the most beneficial, especially for this model of care when the relationship between the provider and patient is so important. And then sustainment in rural areas has just proved to be more challenging. They're actively sustaining group care in a lot of our urban clinics, but getting the funding from the government to sustain in the rural clinics has been challenging. And in a randomized control trial setting, we are able to incentivize individuals to come by giving them a transportation voucher outside of the randomized control setting. Again, since we know that a lot of individuals in rural areas experience transportation barriers, it's been harder to have that uptake and participation. And I'll end with just like a last anecdotal story as I say thanks. And again, there's my email if anyone wants to connect or has further questions. But when I was at our most rural clinic, Bongo, I actually was able to speak with a pregnant woman that walked 4 hours to get to the clinic, had her hour-long group prenatal care appointment, and then walked 4 hours home. So in these low and middle income countries, like when we're thinking about the gravity of being rural and being distanced from a health center, it's that far. And it really does take a lot of effort on their part to be able to attend their visits. But they do it. They do it for the sake of their own health and their baby's health, which was really great to see, but definitely a lot of issues. Okay, I know I talked really fast, and I know we only have 4 minutes left, but let's get the conversation going.
Well, thank you so much to Liane and Dr. Desloge for sharing those insights about rural maternal and child health. We really appreciate all of you sticking on and through to the end here. I will be sharing the references that Liane put in the chat for you all. And we will be also sharing some opportunities that are coming up. So if anybody's about to drop off, just keep these in mind. We are always looking for MCH focused internships. There is a March of Dimes event that's focused on the role of fathers and partners coming up. And we have our website, and you can sign up for our listserv if you are interested in staying connected. But let's go ahead and turn things over to questions. Does anybody want to unmute or drop a question in the chat? We'll pause the recording and take it from there. Thank you.